Hello again. I left off here on this slide. Down at the bottom, I just wanted to say one more thing about safety and medical considerations. Um, some of the antidepressants, depending on their action and their side effects can contribute to somebody's worsening medical condition. So we do have to really be very cautious. On page, let's see, 259, there is, let's see it, yeah, and it ends up on 260. There is a list of basically FDA-approved drugs for major depressive disorder. It's good to just kind of skip through, just kind of jump through the warnings a little bit and just kind of take a look at those. There are certain medications, say for instance, that can't be prescribed if you have heart conditions. And we always have to think about, when we're thinking about safety, we have to think about side effects. And it does look like there are some side effects that can certainly cause great deals of difficulty in people. So we do have to it's really good to just kind of go through that warning, the side effects and warnings on those medications on those pages. So just a little humor, how antidepressants should work. Side effects include weight loss, clear skin, a full head of hair, multiple job offers, abs of steel, loving companionship, sparkling personality. That would be just a wonderful thing, right? That's what we should have for side effects for antidepressants. However, it's not quite that way. But definitely antidepressants do help to improve many patients' lives as long as they can tolerate them. Some people truly can't tolerate antidepressant medication, and then they may have to go to some of the other types of treatments for depression that we will come to very shortly. So we do have SSRIs, and you might be familiar with some of these already. You might have given these in clinical at this time. If not, you definitely will be giving these during your clinical on 1K. And pretty much they're the first line therapy, the first thing that a physician is going to order usually. There is a rare risk of serotonin syndrome. So we do always have to worry about serotonin syndrome, especially if people are on multiple medications that all deal with serotonin, then people are at higher risk. There are SNRIs, so the serotonin norepinephrine reuptake inhibitors. SSRIs may actually be tolerated a little bit better as far as side effects, but those are probably the two most common classifications that we're going to see ordered. Tricyclic antidepressants are pretty much the old antidepressants, and I do see them once in a while. They are still prescribed. Many times, if they are prescribed, they are given at night because they also have sedating side effects. They also have anticholinergic adverse reactions, so you have to be really careful and watch for things like urine retention, which could actually be quite serious. Some of the other just really common side effects to tricyclics could be a little bit of blurred vision at first, but usually that's minor and it goes away as the person adjusts to the medication. The dryness, that type of thing, all those anticholinergic adverse reactions that you're kind of aware of already. But probably the most significant one would certainly be urinary retention. Actually, some of the old antidepressants, the tricyclics, some of those medications are actually used to treat bedwetting in children. So because of that side effect. Okay, monoamine oxidase inhibitors, or MAO inhibitors. These aren't used very often. Actually, in practice, I hardly ever see these prescribed anymore. They are effective for unconventional depression that maybe doesn't respond to the other medications, but there's a lot of risky things associated with MAOI inhibitors, such as you can't take them with many different types of medications. Matter of fact, if you go in your medicine cabinet now, and look at some of the over-the-counter medications that are in your medicine cabinet, you're going to see that you can't take those medications while you're on an MAO inhibitor. You have to be off of the MAO inhibitor for at least 2 weeks, or if you were taking something either prescribed or over the counter on a regular basis, you have to be off of those medications for at least 2 weeks before you can start your MAO inhibitor. And there's a lot of dietary um, restrictions that you have that might be a little bit hard for people to follow. So, wine, beer, aged meats and cheeses, sausages, things like that, coffee to a certain extent, colas, and chocolate also are some things that I can kind of think of offhand that are on that list. There's a few other things. I think overripe bananas and things like that that contain larger amounts of tyramine. And if you are eating foods that have large amounts of tyramine and you take an MAO inhibitor, you have a risk for hypertensive crisis. So your blood pressure will go very, very high. And of course, with that, you can always have that risk of having a stroke. So it's really important to make sure that if people are on an MAO inhibitor, that they really have good information. They know exactly what foods and medications to avoid, because we don't want them to risk having hypertensive crisis. Other treatments for depression, ECT actually is a wonderful treatment for depression. And maybe some of you are thinking, are you kidding me? It really still exists. People get ECT. It's electroconvulsive therapy and used to be called shock treatments. So if you have ever seen the movie One Flew Over a Cuckoo's Nest, that really gives a very, very bad image to electroconvulsive therapy. And actually, in the way olden days, it probably was given inappropriately at times because there weren't many medications or treatments available. And when they first started using shock treatments, they did not anesthetize the person. They did not go under any type of general anesthesia or muscle relaxant. So they were awake and they would have a full-blown tonic-clonic seizure, and sometimes people would hold them down during the treatment so they wouldn't fly off the table, but then sometimes bones were broken. So it does kind of have a bad rap from years ago when the treatment was first developed. But it is certainly done in a much more humane way now. They're given a short-acting anesthesia and also a muscle relaxant. So they need to be bagged during the procedure because they're kind of losing their breathing just for a very, very short amount of time while the stimulus to their brain is being delivered. We used to do ECT treatments at Sheboygan Memorial Hospital. However, they are no longer offered there. So if people need this treatment, they're going to have to travel to a bigger city. So I know that there are hospitals in Milwaukee, for instance, and Mequon that offer ECT treatments. And I'm sure larger cities across the nation all still offer this treatment. It truly works very, very well. It can work very quickly, more quickly than the antidepressants work. And actually, even though you're going through a little bit of short-term, very short-acting anesthesia, it actually has less risk of negative effects and side effects than medications do. So it can be a very effective treatment. I used to take every single clinical group up to the PACU on the 5th floor at Sheboygan Memorial to watch ECT treatments, but they're just not, it's just a matter of the physician just chooses not to, probably is approaching retirement and just chooses not to provide that treatment any longer. And some people get ECT treatments as on a short term, and then they continue on with medication just to kind of, well, I guess in some ways to kind of jumpstart their chemicals in their brain so that they start getting out of their depression and then they can continue to get well with medication. So sometimes I've seen it used that way. And I've certainly seen it used like 3 times a week for 2 weeks, which is kind of a standard way to start the treatments in order for that person to really lift out of their major depressive episode. I've seen it work really quickly. And again, I think I mentioned this when we were talking about bipolar, but I've actually seen people go from a major depressive episode right into mania even after one treatment. Actually kind of interesting to note that ECT was actually discovered in the 1930s, and basically because people were paying attention to and aware that patients that had psychiatric disorders that actually had a seizure disorder on top of that, after they had a seizure, they actually felt better. Their mood was better. So doctors were making the connection between patients having a seizure and an improvement in mood. So way back in the 1930s, this was being discovered and worked on. And of course, again, today it is much more humane, and we would give that in a very supervised setting in the PACU where you would recover from surgery, so that people are being very, very closely monitored. Some patients received continuous after that, like 3 times a week for 2-week period. That's the initial thing to get them better, to bring them out of their depressive state. Some patients, again, would get medication, and then they would kind of continue on their journey to wellness and lifting their depression. But some patients who weren't able to tolerate medication actually would get maintenance ECT, and that would be about every 4 to 6 weeks. And a patient would just come back for a treatment every 4 to 6 weeks. And some of the patients that I know that had received that treatment received it for years as a maintenance program because they couldn't tolerate medication. Nothing else worked for them. But if they came in for their treatment every month or so, month and a half, then they would actually stay well for long periods of time. Another interesting treatment, there's a bunch of interesting treatments: the transcranial magnetic stimulation, vagus nerve, and deep brain stimulation. At this point in time, I'm not aware that those are being offered in Sheboygan or even Manitowoc. I would guess, again, that you would have to travel to a larger city. I'll have to find out when the school year begins if any of these more innovative treatments are being offered in smaller communities yet. But these 3 also show great promise for people that have symptoms of depression that are just unrelenting, and they perhaps medications either don't work for them or they can't tolerate medication for whatever reason. The biggest differences between those 3 types of stimulation, brain stimulators, is that the transcranial magnetic stimulation is non-invasive, and that's using magnetic pulses to stimulate focal areas of the brain. The vagus nerve stimulation and deep brain stimulation are both more invasive, and of course, anytime you do anything invasive, there's always risk factors associated with that. Light therapy, I kind of mentioned already, as a treatment for, it's really the first line treatment for seasonal affective disorder, again, which is like a subtype of major depressive disorder, and in which people have seasonal patterns. So right now would not be a high time for people to be experiencing that seasonal depression, and they probably wouldn't need light therapy as long as they're getting outside and getting some sunshine. But it is, again, it's a very, very effective way to treat that type of depression. St. John's wort might be helpful for, a minor depressive episode, but truly its usefulness in severe depression hasn't really been established. I do remember when this first came out as an herbal supplement, and boy, it was just touted as this is the new cure for depression, and everybody who has depression should be on St. John's wort. It's natural, it's an herbal. But with all naturals and herbals, we always have to be careful of side effects and also interactions with other medications that the person might be on. And really, and if you read in the book, on page 266, it does say that it does have a potential for adverse reactions, and neither safety nor standardization of dose has actually been established. So really, it should be used with caution. And as nurses, I guess I wouldn't even necessarily recommend this to anyone. I would probably recommend light therapy or exercise or something else as an adjunct. exercise and light therapy, things like that. I mean, yes, light therapy can be like the first line of defense for seasonal depression, but if somebody has a major depressive episode, I would recommend them getting to a doctor and even either receiving one of these somatic type, the brain stimulator or ECT or medication to help their depressive episode. So really light therapy, St. John's wort, and exercise kind of can be adjuncts, but not necessarily things that are going to help a major depressive episode. So I just want to say just a quick thing about exercise. If somebody is starting to feel a little bit depressed, like they have a recurring depressive disorder, increasing their exercise might be helpful. But again, it's more of an adjunct. It's a help in aiding the decrease in depression, but in and of itself, exercise is not enough to actually treat and bring somebody out of a major depressive episode. But of course, it is very helpful in terms of just overall body health, and it does help to decrease depression and anxiety symptoms. So again, back to ECT a little bit. It can also be used for psychotic illnesses, but I honestly don't see it used for that as much. But you really want to think about ECT if somebody is really very having severe malnutrition because of their depression, that it's so severe, they're so exhausted and dehydrated because the depression just isn't getting better. Again, safer than meds. And sometimes if people have a delusional depression, it can be very helpful. So they actually have ideas that are not based in reality. And again, failure of previous medication trials, and sometimes people that are catatonic can respond to ECT. So just a quick summary of all of these. Transcranial magnetic stimulation, again, that's the only one that's non-invasive, and the presence of metal is the only contraindication. There can be some adverse reaction, rarely seizures, but of course that would be the most serious of the side effects. Vagus nerve, originally used to treat epilepsy, decreases seizures and improve mood. Electrical stimulation boosts the level of the neurotransmitters. So again, you can have some side effects, but nothing very, very terribly serious. But that voice alteration, depending on what you do for a living, if you're a singer, that could be, or use your voice every single day in your job, that might be something that could be a difficult side effect. So about 60% of patients have a voice alteration. Deep brain stimulation, surgically implanted, stimulates the regions identified as underactive in depression, much more invasive than vagus nerve stimulation. Electrodes are placed directly into the brain. So again, anytime you have something that's that invasive, there are always side effects and things to worry about, especially risk for infection. So again, light therapy, I feel like I already talked about that. The negative effects possibly could be headache and jitteriness. And again, you have to kind of monitor what time of day you're using it. If you're using it late at night, that would not be a good idea, would probably impact on your ability to get some sleep. I talked about St. John's wort already, and I did talk about exercise already. Exercise always is a very helpful thing, and it's not going to be harmful to somebody unless they have a cardiac or respiratory medical condition that prohibits them from exercising. I wish that they had exercise groups on 1K a little bit more often. They used to have the exercise room open twice a day for patients, and now it's kind of down to once a day, if that often. So advanced practice interventions, psychotherapy, of course, is always something. Cognitive behavioral therapy, interpersonal therapy, group therapy is also something that an advanced practice nurse can promote. An advanced practice nurse is going to be leading group therapy, and some patients really don't like group therapy, so it's a helpful thing, but we always should be trying to at least encourage patients on 1K to be going to group therapy. There are lots of different outpatient groups also that can be led by nurses. The group therapy in the hospital is actually led by occupational therapists, and they both have master's degrees. They're very well prepared to lead those groups, but a nurse-led group has a nurse has a very different perspective than an occupational therapist would, and has more of the medical perspective and knowledge of how the medications work. So a nurse is actually a very great person to be leading group therapy. The future of treatment, well, Healthy People 2020. We're coming up on that pretty soon. This is 2019 already. I'm wondering where we are in our objectives and meeting our objectives about um, improving screening for children and adolescents in a variety of health and community settings, reducing the incidence of depression episodes in children, adolescents, and adults, increasing mental health treatment in primary care. So sometimes patients don't really want to go to a psychiatrist or a psychologist. And quite honestly, there's a shortage of those practitioners. So it may not even be possible to get an appointment right away with a specialist. So more and more, I know that we are treating people for mental illnesses in the primary care setting. So you go to your regular medical doctor or nurse practitioner, whoever your healthcare provider is, and there are times that that person can at least start to provide some mental health care. So that is actually very helpful, even though they're not specialists. It's helpful because it is hard sometimes for people to get in for an appointment. It may be, quite a bit of time. The other thing that's an issue sometimes is with people getting treatment is, of course, insurance coverage. So that's something else that we kind of have to think about. And if we're not meeting these Healthy People 2020 objectives, it's very possible that we have to do something more along the lines of insurance and making sure that people are able to get the care that they need. And increasing the number of patients with depression, both children and adults, who actually are receiving treatment. Many people with depression, and children too, don't get the treatment that they need. So those are all very important aspects, and hopefully we're moving ahead on some of those goals. We always have to look at the nursing process, and we always want to do an evaluation. So we want to evaluate where they're at with their suicidal ideation. I think I mentioned this somewhere, probably in Learning Plan 1, that we do use rating scales. You can use a rating scale on a scale of 1 to 10. How suicidal are you feeling today? We are really hoping that if they came into the hospital at a 9 or a 10, that they are now feeling maybe even at a 1 or a 2. Perhaps they are never going to be rid of their suicidal ideation, but if it's not so intense, it's something that they can learn to manage. We want to look at their intake. Are they eating and drinking appropriate amounts of food and fluids? Are they maintaining their weight? We have to look at their sleep pattern. If they're getting a certain amount of sleep during the night, or are they sleeping all day still and then trying to sleep at night also? Are they having sleep alterations where they're waking up and they can't get back to sleep? How's their personal hygiene and grooming? How is their self-esteem? How do they feel about themselves? Do they feel that do they feel that they are a person who is worthwhile of other people's affections? Do they feel a valuable member of their family and of society? Social interactions. Are they by themselves a lot? Are they spending time by themselves? They don't have the energy to socialize with other people. Look at that anhedonia symptom. Are they feeling pleasure in activities? Do they enjoy being with people or enjoy activities that they used to enjoy? So all those things are things that we really have to look at. So again, a little bit of QSIN thrown in, quality improvement. So again, those national goals in Healthy People 2020. So we really want to make sure that at least 75% of people are getting treatment. The number of physician office visits whose routine screening for depression, and the Center of Quality Assessment and Improvement on Mental Health, and we want to provide links to reliable outcome measures. So quality improvement is very important in mental health and when you're considering depression. So the last chapter now in this learning plan is suicide and non-suicide self-injury. So suicide is the intentional act of killing oneself by any means. Suicidal ideation is thinking about killing oneself, so it's having ideas and thoughts and possibly even plans. A completed suicide is a suicide that I hate to even say the word successfully because that really isn't a good word to say. Basically, that the person their actions of suicide resulted in death. Non-suicide self-injury is self-injury directed to the surface of the body to induce relief from a negative feeling or cognitive state, or to achieve a positive mood state. If you talk to people that self-injure, they will tell you that they feel better. They feel a relief from their intense feelings, anger, anxiety, depression. They feel better after they self-harm. So that is different from being suicidal. Many times people that are self-injurious, self-injurious, do that in order to prevent themselves from committing suicide. It is basically a coping mechanism. It is not a good coping mechanism. It's something that we should work with people to try to change. However, we have to look at it as a coping mechanism. So the epidemiology, it's the 10th leading cause of deaths in the United States, second leading cause of death for ages 10 to 34. These are pretty alarming statistics. Fourth leading cause of death for age 35 to 54, and eighth leading cause of death for ages 55 to 64. So suicide rates among active duty service members has surpassed civilian rates. Again, a very alarming statistic. Suicide rates among veterans is increasing more rapidly than that of the general population. So that tells you right there a population that we really need to focus more on. Okay, so now we have a little case study. Gino, 14, identifies as transgender, saying, I've known since I was real little that I was meant to be a girl. I'm a girl on the inside and always have been. As soon as I'm of age, I'm going to get surgery for gender reassignment. I've been saving my money for it for as long as I can remember. In the meantime, I asked my friends to call me Gina instead of Gino. I grew up with these same kids, so with my friends, it's really no big deal. So we do have to think about people that have issues with either being transgender or possibly being lesbian, gay, any of those other sexual alterations, that sometimes that really puts people at risk for suicide. Case study continued. This year, however, things have changed a bit for Gina. Growing up in a small neighborhood school in the city, she has now entered a new, larger school. She doesn't always have classes with her friends, and she's beginning to get pushed around in the halls. Recently, Gina, who dresses and grooms herself as a girl, tried to use the girls' bathroom, which is allowed at her small private school, and a teacher followed her in and shooed her back out, calling her disgusting. So I don't think that this little case study that the textbook authors came up with is that far off the mark. There definitely is, treatment that is very, very prejudiced and difficult that people who are transgender are experiencing. So, risk factors for suicide. Absolutely, having a diagnosed psychiatric disorder is a risk factor. And some of the major illnesses we have yet to cover in different learning plans, but things like obviously major depressive disorder is a huge risk factor for suicide. Bipolar disorder is another huge risk factor for suicide, but we haven't yet talked about schizophrenia, so that is another population that suicide is very common, and also people that have eating disorders have a great deal of difficulty. We're going to be talking about personality disorders in the next learning plan, and quite honestly, those patients probably make a lot more attempts. Some of them do, of course, commit suicide, but many of them make multiple attempts as a coping mechanism or use a lot of self-harm. More do that than actually commit suicide. So we do have to look at having a diagnosed psychiatric disorder. Using alcohol or substance abuse and having an alcohol or substance abuse disorder. And I just want to differentiate because sometimes using alcohol and becoming intoxicated, even if you don't have a substance use disorder, but sometimes just when people are intoxicated, they do things that they wouldn't normally do if they weren't intoxicated. So again, alcohol truly is a depressant, and sometimes people under the influence of alcohol feel depressed and suicidal and may even make an attempt when they normally wouldn't feel that way if they weren't intoxicated. I did see somebody a few years ago admitted to 1K because they made a suicide attempt while they were intoxicated, and when their blood alcohol decreased and went away, as they sobered up and they were in the hospital, they actually couldn't believe what they had done, that they had actually made a suicide attempt, because that was not something they ever would have thought of if they had not been intoxicated. So, and certainly people that chronically use substances or alcohol are at, again, very, very high risk for committing suicide, not only because of the fact that those substances are decreasing their inhibitions and maybe making it more likely for them to follow through, but also sometimes the chronicity of those conditions, and people can feel very helpless and hopeless to get over their addictions and sometimes turn to suicide. Male gender is a huge risk factor. So we have to really think about reasons why, and maybe sometimes society puts different expectations and stereotypes on males, and if they feel they can't keep up with those stereotypes or somehow feel weak and not quite like the strong male that they think they should be or society thinks they should be, that can definitely put them at very high risk. So males actually have quite a bit of different stressors in their lives than females do. And it is shown that men commit suicide, I believe it's about 3 times the rate that women do. Women make more attempts at suicide, but men complete suicide a lot more frequently than women do. Increasing age. So we can't just say, oh, the sweet little grandma or grandpa that's on the unit, they're in their 70s or 80s. They wouldn't do anything to hurt themselves or kill themselves. They are actually at very high risk. Older people can and do commit suicide. They make suicide attempts. They feel suicidal. There are lots of reasons why an older person might be suicidal. Again, depression is not part of getting old, but there are certainly lots of different stressors and changes that are associated with increasing age. Race is a risk factor, so 85 to 90% Caucasians. Caucasians are committing suicide at a much higher rate than other races. On page 476, there's a nice box called Suicide Facts. It's green. That is very worthwhile to kind of read through. I'm not really going to be asking you for statistics on exams. However, it is useful to know, and I did make a little bit of a mistake. Sorry, I will correct that right now, because it used to be males committed suicide 3 times. Now it's nearly 4 times. So males take their own lives nearly 4 times the rate of females and represent 78% of all U.S. suicide. So I just wanted to correct that because I think I said 3 times. So it's actually men take their own lives 4 times the rate of females. So that's very important to consider. And I'm certainly, just to know that 85 to 95% of suicides are Caucasians rather than other races. That's kind of valuable, but I know that table, there's a lot of statistics that they go through, and I'm not necessarily going to be asking you, I'll send out a kind of a roadmap for the exam shortly. So it's not, I'm not going to be asking you to kind of spit back some of those statistics. People that have religious faith, sometimes, again, I think I mentioned already that some people's religious faith is actually a protective factor, which means that it's something that helps them to prevent committing suicide, but there might be some religious denominations or viewpoints where perhaps if the person really doesn't feel like they're kind of fitting in with the other people in their denomination, they may feel very much alone and apart, and that may be actually a precipitant. But many times, if people have religious faith, that is something that can actually be very helpful. On page 478, the book actually says that Protestants and Jews have higher rates of suicide than Roman Catholics do. So that's just kind of another interesting aspect of religion. Marriage, being married, especially if you have children, significantly reduces the risk of suicide. Divorced men are more likely than divorced women to kill themselves. So again, having those protective factors of having people rely on you. So perhaps your spouse needs you and you need each other and the children need you. So that could be a protective factor that will prevent that person from committing suicide. Although there are people that are married sometimes that do commit suicide. So these are kind of just risk factors in general. A profession. Professionals are generally considered higher risk for suicide, especially if there's a loss of status. So especially think about a male who has a very high-ranking job and all of a sudden loses his job. That can feel completely devastating, like their whole life is lost. So we really have to take a look at that loss in status. So for physicians, dentists, veterinarians, chiropractors are at very high risk. Law enforcement, sales personnel, mechanics, insurance agents, and lawyers are also at high risk. And actually, it says over the past several years, there's been an increased risk in construction workers and heavy equipment operators. So, but usually, heavy equipment operators and construction workers would be considered more blue collar workers rather than the professional worker. So, and again, just think about the amount of stress and responsibility that's in a job that could be impacting. Physical health. So people that have chronic illnesses have an increased risk of suicide. Think about the losses that might be associated with their illness. If they have loss of mobility, if they're disfigured, they have chronic pain. Again, pain is a huge, huge factor with suicide. So all things that we have to consider when we're thinking about a person's possible potential for committing suicide. So we always have to look at familial tendency and low serotonin levels. So there is a family history. If there is a family history of depression, that absolutely puts that person at higher risk. It puts the patient at higher risk. I'm always alert to listening for this in report when I hear about somebody who has their father, their grandfather, and their uncle all committed suicide, or their brother. It just immediately sparks in me, wow, this person is at really, really high risk. On page 476 in your book, it gives a really good example of a very famous person with a familial tendency, and that was Margot Hemingway, and she committed suicide in 1996. She was the fifth suicide among 4 generations of writer Ernest Hemingway's family. So very, very significant. Psychosocial factors. Yeah, there's a couple of different theories. Freud, aggression turned inward, and Menninger's 3 parts to suicide hostility, the wish to kill, the wish to be killed, the wish to die. Aaron Beck's central factor of people being hopeless. We definitely always need to think about that diathesis stress model. So the combination of suicidal thoughts and fantasies and the genetic predisposition, and combined with perhaps a significant loss or stressor. So stress and genetic predisposition is usually what we think about as something that is a significant contributor to suicide. There's also something called copycat suicides. And I just kind of can't help but wondering, So, copycat suicides. Your book talks about this in the paragraph on environmental factors on page 477. And I can't help but wonder if when Anthony Bourdain committed suicide last year, pretty quickly after Kate Spade committed suicide, I kind of wondered if his death was kind of in part precipitated by hers. Not that he didn't have his own issues and his own depression and illness going on, but sometimes when a suicide follows a famous person, somebody who's very well known, it can be considered a copycat. So, and again, I know that he also had some mental health issues going on, but perhaps he kind of got the courage that he needed because of her suicide. So we do have to take a look at that. It is very important for us to take a look at the issue of copycat suicides in teenagers, because sometimes if a classmate commits suicide and the teenagers are their brains are just really very immature, and that might spur an adolescent to also make a suicide attempt, or just in the general population too. If a famous person commits suicide, it's very possible for, again, that to kind of precipitate suicides even among the general population, not necessarily another famous person like it was with Anthony Bourdain following the death of Kate Spade. But we do have to think about that as a significant issue and really pay attention to the way that somebody in your life, perhaps, or somebody that you're assessing is taking care, it's not the taking care of, the way that they're reacting to that suicide. So if they're envious of that person that committed suicide, that would be a huge thing to look for. So if they're making statements like, oh, they're so lucky, they've got relief now, they're at peace, that would be a huge warning sign that that person is most likely thinking about a copycat suicide. So LGBT youth and bullying. So again, the little case study kind of is a good example of that. That is something we really have to concentrate on. So this population is really very vulnerable. They're the targets of online bullying, face-to-face bullying, name calling, verbal and physical harassment. So those are all things that really make it much more likely that they're going to be suicidal. White, LGB, and Hispanic bisexual females are more likely to be bullied than white heterosexuals, and a Black person's LGB's vulnerability to bullying was about the same as white heterosexual youths, and sexual minority youths were more likely to report suicidal ideation. So again, another population that we as nurses really need to focus on. Bullying in general is certainly another issue. We could probably talk for a couple of hours, but you're probably hoping that I'm just going to get through this learning plan and not talk for a couple more hours, but literally we could, and maybe that would be a good topic for a post-conference discussion during clinical, really talking about the effects of bullying on people and how bullying is so prominent and prevalent these days, especially bullying through social media. You know, in the olden days, you could go home to your own home and your neighborhood and you could get away from the bullies at school. But now, because of social media, you can't get away from them. They're there all the time. You can be bullied at home, in your own home, in the safety and comfort and privacy of your home. You can be bullied by people. So that is something else that we really have to think about in general. And then if you throw having a sexual orientation issue on top of that, really makes people very vulnerable. So other cultural factors, a protective factor is actually being African American. Many times religious beliefs and extended family. So just the closeness of all the different generations of the family can actually serve as something that's very much of a protective factor. In Hispanic Americans, the Roman Catholic religion, which is prominent, and again, the importance of extended family. So those two issues can really help. to be protective factors, so things that would prevent somebody from committing suicide. And in Asian Americans and adherents to religions that tend to emphasize the interdependence between the individual and society. So anytime people's connections are increased, so if you're connected to your family, you're connected to your church, your religious beliefs, those types of things can really help people to prevent them from committing suicide. So societal factors, again, we could talk probably for hours about different aspects of society. Just, however we think about and value or don't value life in general. So if we look at issues like assisted suicide, there are some individual states that allow, regulate, or prohibit assisted suicide. So it's really up to the state, and some states are moving towards assisted suicide. And in the Netherlands, Belgium, and Switzerland, assisted suicide has been legal really for quite a long period of time. That whole issue of assisted suicide truly is an ethical and moral dilemma, and it really is very, very muddy. There's just no clear-cut answers to any of those issues. So we as people in society really tend to struggle with those issues. Suicide bombing, the DSM-5 really excludes religious and political suicides from its criteria, mostly because it's considered an honor to die in defense of their faith, and that they believe that real happiness exists beyond this life, and for them they're kind of a martyr if they're a suicide bomber. They're not doing it to kill themselves because they can't stand their life or they're so depressed, but it really is for them an honorable entrance into the afterlife. So we really don't consider it the same thing as we do suicide. Clinical picture, risk assessment, suicide attempts. If a person makes one attempt, it puts them at risk for future attempts. So that is always something that we are assessing in the clinical area. And it is alarming sometimes when you hear how many attempts that people have made. And many times the attempts actually get worse and worse and worse, more serious, more lethal as the person makes more attempts. So the lethality might have started out kind of low. Taking an overdose is actually considered a low lethality method. So in other words, it's not likely to end in death. So that maybe even though people do die of overdoses, but it is considered a lower lethality method. So maybe that person started out with a lower lethality method and that didn't work. And so maybe now the next time they're going to try hanging. Their attempt got interrupted. Somebody saved them. And now the next time they try an attempt, maybe they're going to use a gun. So usually we see a progression in the lethality as people make more and more attempts. So it's really sad, too, that on average, only about a little more than half of reported attempts receive adequate mental health treatment. It is always horrifying to me when I hear about somebody that made a suicide attempt and they were sent home from the emergency room the same day or the next day. They weren't even kept in the hospital, to get mental health treatment. That is just horribly alarming to me. So in the DSM-5 suicide behavior disorder, the criteria are that they made an attempt within the last 24 months. It was not initiated in delirium or confusion, and the attempt was not undertaken for a religious or a political objective. So I would say most of the patients that we see in the hospital are going to they're going to meet the criteria for this disorder. So application of the nursing process. We really need to look at all of the different factors for assessment. On page 478, there starts a whole paragraph called application of the nursing process, and there's a paragraph called assessment, verbal and nonverbal clues, lethality of the suicide plan, and self-assessment. So all really good stuff to read over. So when we think about the verbal and nonverbal clues, we think about overt statements. And the overt statements are things that people say that are just right out there. It is not hidden. It's not, you know exactly what they're saying. So many times they say, I can't take it anymore. Life isn't worth living. I wish I was dead. Everybody would be better off if I died. Um, or I'm thinking about, they may even say something like, I'm thinking about killing myself. I really want to kill myself. So that's very overt. It's out there. You don't have to guess what they're thinking or feeling. Covert statements are a little more subtle. It's okay now, soon everything will be fine, things will never work out, I won't be a problem much longer, nothing feels good to me anymore and probably never will. Although they've got one listed here that I kind of disagree with. How can I give my body to medical science? If you're saying that, I think that's a little bit more overt than covert if you're talking about donating your body to science. But anyways, many times it is definitely a relief for people to talk about their suicidal ideation. This might be an area that's kind of difficult for you as a nursing student, or even as a new nurse, no matter what area you end up working in. It just feels like it's so very personal, and like you're really delving into an area that is so private and so personal. But it is so important for us to ask the question and to be very direct and open when we're assessing for suicidal ideation. So if we hear some of those overt or covert statements, we really need to take action, and we need to further assess a patient's suicidal ideation. So we will talk about this also when we're going through clinical orientation, because that is something you're going to do every day that you're at clinical. You're going to be asking a patient if they feel suicidal, if they have a plan, if they feel they can keep themselves safe in the hospital, and if they agree to keep themselves and everybody else around them safe. So lack of suicidal or homicidal ideation, we're wanting to know, can they control themselves while they're in the hospital? So it is very important to look at those overt and covert statements. We always want to look at the lethality of the suicide plan. And again, low lethality methods, or in the book they call them soft methods, do include overdosing. So ingesting pills, inhaling natural gas, and cutting one's wrists. So it's not that you can't die from those, because certainly people do die from those means, but they aren't as lethal as some of the other methods. So the high lethality methods, or high risk hard methods, include using a gun, jumping off of a high place, hanging, poisoning with carbon monoxide, staging a car crash. So those are all considered higher lethality methods. We do have to take a look at that and consider that when we're assessing somebody's suicidal ideation. Also, when they're in the hospital, we always want to think too, when we ask them what their plan is, we always have to think in the back of our mind, is this something that they could accomplish in the hospital, or is this something that they're thinking about doing once they're home? Because if they're saying they want to stage a car crash, or they're thinking about using a gun, they don't have access to those things. Jumping off a high building, they don't really have access to that at the hospital, unless they escaped and somehow got up onto the roof. But we always have to take a look at, is this something that's going to be a problem with them acting out and trying to make an attempt in the hospital, or is this something that they're planning on doing once they go home? So it is important to communicate very clearly and to try to figure that out. So one of the things that we really have to think about too, again, is that self-assessment, because we might be really worried, anxious, fear, grief, anger, puzzlement. We might condemn suicidal feelings. How could anybody think or feel that way? So we might have very intense emotions that are involved with suicide. We might have very strong feelings against people that have suicide. Society certainly stigmatizes people that commit suicide. I see it all the time in social media, and maybe some of you do also. The comments that people make when there is a suicide, many times people are called selfish. They're only thinking about themselves. They don't care about other people. they should have just picked themselves up and carried on like they really didn't have an illness going on, that they were cowards, they took the coward's way out. And maybe you can think of some other types of statements that people make when people are suicidal, all very derogatory and condemning towards that person who is suffering. So we have to remember that people that are suicidal or do commit suicide, they have been suffering tremendously, and many times they feel that there's such a burden that they actually feel and believe deep in their hearts that people in their lives would be better off without them and that they won't even miss them. I have talked to people after they've made a suicide attempt and they have lived, and I've asked them about, how do you think your family would feel if you had actually committed suicide, if you had died? And many times they just look shocked and say, "Well, I never even thought about that. I just thought they would be relieved. I thought they'd be happy to be rid of me and that they would just get over it in a week or two and go on with their lives even happier than before." They truly are not doing it to hurt other people. So we really have to try to be empathetic and really understand that people that are suicidal or commit suicide, they're actually really suffering quite a bit. So, discussion question. You're worried about a close friend who recently broke up with a boyfriend. She is taking the breakup very hard and seems depressed. What are some questions that you could ask to assess for suicide ideation? So, I'm hoping that you're thinking about, are you feeling suicidal? Are you feeling like taking your own life? Just you can be very direct. It might be hard to be direct at first, especially with a friend. So you could start out with something more gentle and say something like, are you feeling like life isn't worth living? Are you having a hard time with life right now? Do you have any hope for your future? You can kind of gauge it that way and then kind of move into the more direct. But we want to make sure that they don't have suicidal ideation. And certainly we want to find out if they do, if they have a plan and what the plan consists of. Those are all things that are very, very important to find out when somebody is feeling suicidal. So again, health professionals might experience fear, grief, anger, puzzlement, all of those things. One thing that I didn't mention before when I was talking about this is that it is so helpful to acknowledge our feelings to team members to avoid countertransference. So if you remember what that is from Learning Plan 1, that would be a negative reaction on our part. Basically, especially if we have somebody in our own life that perhaps committed suicide and now we have a patient that kind of reminds us of that person, it might be very hard to work with them therapeutically. So to talk to other team members to avoid having any kind of a negative reaction or ending up treating that person poorly because of your own personal feelings. So some nursing diagnoses that would apply: risk for suicide, self-care deficit, sleep pattern disturbance, altered nutrition, anxiety. And again, we're always trying to plan goals, and suicide self-restraint is one of the biggest goals. So we want the patient to agree not to commit suicide. So again, we ask them to contract for safety every shift, and we want them to be able to control themselves as much as possible. Yeah, we can have external controls placed upon them, and if you think about it, being in the hospital is in and of itself like an external control. They're not at home. They don't have access to things. They can't just leave and go get a gun. They can't just leave the hospital unit and go and buy some pills and overdose on them. They are in a locked unit. So that in and of itself kind of gives them some external control. We want them also to develop internal control so that they can control those impulses until they're starting to feel better. So interventions, we want to prevent suicide. We want to promote activities that provide support, information, and education to prevent suicide. Again, encouraging the patients to attend group therapy is very, very helpful, whether they're on an inpatient unit or there's actually nice outpatient opportunities for group therapy related to depression and suicide. And treatment is treatment of the actual suicide crisis. And postvention are the interventions with a circle of survivors left by individuals who completed suicide to try to reduce the traumatic after effects. Of course, it's always going to be traumatic to lose somebody to suicide, but a suicide survivors group is a very good example of tertiary. So these are really primary, secondary, and tertiary levels of prevention, which those three concepts also we're going to be kind of revisiting throughout many of the learning plans. So interventions, psychosocial, psychobiological, medications, safety and teamwork. Again, we here report on the whole unit. If somebody is feeling suicidal or has a plan or made an attempt, everybody needs to be aware of that. Your book really does a great job of going through all these different types of interventions. I do want to point out, however, that I really believe that the psychosocial interventions, the actual making that therapeutic relationship connection to your patient is, again, so very important. Kind of goes back to that first learning plan where I talked about how much I absolutely loved Hildegard Peplau's theory and that she truly is my role model and my hero. She is the mother of psychiatric nursing, and truly her theory is based on that interpersonal relationship. So nothing takes the place of that relationship. And actually, that relationship can be more powerful than any screening tool that we have and any other types of interventions, is that making that connection with that person. So very, very important part of the intervention. So psychobiological, of course, we're monitoring patients on medications. Safety and teamwork, again, we all are interacting with people on the unit, not just our own assigned patients, and that we all have to work together to keep people safe. And health teaching and health promotion. One thing that I think is really interesting that your book talks about on page 480 under intervention is that in terms of community intervention and training people out there in the world to, to assess, not really to assess. Okay, they can't assess because they're not nurses, but it teaches the ordinary citizen to recognize, that's a better word, depression and suicide in people in their own families and communities, and that is called QPR, question, persuade, refer. So that's really interesting that that's in this book, because I am a QPR trainer and I've done a couple of community presentations, and actually I do a QPR training session for you as part of your clinical experience. So you will all be QPR certified if you aren't already. Some of you may have received this training from Christy Irving, or perhaps if you work for Aurora, perhaps you've received this training already through Aurora. But if you haven't, I will be going through the presentation and giving you a QPR certificate. So I'm actually really thrilled to see that the textbook is actually mentioning that as a really huge intervention and really big aspect of preventing suicide in the community. So talk about health teaching and health promotion, really getting the word out there with family members and friends as to what to look for. Case management, so sometimes people might need multiple types of healthcare practitioners, and so it's always helpful to have somebody kind of monitoring all of that to make sure that they're getting all their healthcare needs met. Documentation, of course, is a very important part of the role of the nurse, and we need to document very, very clearly somebody's suicidal ideation, their plan, and all of the statements that they're making regarding suicide. I can't tell you how valuable your progress notes are in the clinical setting, because the student progress notes are usually pretty thorough and long, which is great because the staff do read them. The doctors do read your notes. Yes, they do. and they get pertinent information from your notes that sometimes maybe the patient didn't tell the staff nurse, but they told the student. So it's very important when we get to clinical to be documenting a person's suicidal ideation. There have been times where discharges have been stopped because of the documentation of a student. And usually the type of thing that would stop a discharge would be that the patient still complains about suicidal ideation and that they had a plan for when they still had the intention and the plan for when they went home. And sometimes that isn't always documented in other notes because maybe they didn't want to tell another staff member, but they feel like, oh, they can tell the student. So really important for us to communicate and pass things like that on. So documentation, I can't stress the importance of documentation enough when we're thinking about people that are thinking about committing suicide. Again, I already talked about postvention for survivors of completed suicide as something that a nurse could possibly be involved in. Environmental safety guidelines. So again, we kind of talk about this in clinical also, but we don't, well, it says, this is from the book, use and count plastic utensils. We don't use plastic utensils on 1K. There are a lot of there's a lot of different varieties of different types of utensils that might be used across the country, and some of them are actually quite expensive. And we actually, at the Sheboygan Memorial Hospital, actually use metal silverware. It's that the patients usually get a fork, a spoon, and a butter knife, all of which are metal. And of course, you can do damage with all three of those utensils. So they are only allowed in the dining room, and the CNA is monitoring the patients who are eating in the dining room, and the CNA will also count the silverware as the patient is returning their tray. And if the silverware isn't all there, then they would need to ask the patient to hand over the knife or fork or spoon, whatever it is they're trying to hide in their pocket. And that has happened several times. So we do have to monitor that. We actually don't allow plastic utensils on the unit at all. Right now, they're using something called a styrofoam scoop, which is basically cut out of a styrofoam cup. And it's something that enables a patient to eat something that ordinarily they would use a spoon for, but they can't take that spoon to their room. They can't, if a patient wants to eat in their room, they absolutely cannot have any utensils in their room except for that styrofoam scoop. However, it'll be interesting to see what happens, because I did find online an alternative to that that's kind of like a heavy duty, like a coated cardboard, almost like an ice cream container, that type of consistency, which is more of a disposable kind of a scoop that would be better than styrofoam cups. So we'll see if 1K goes to using those. But it is very important to think about, utensils being out on the unit. And again, they're just not allowed at all, except in the dining room. No private room. Well, that's not accurate. So again, this is coming from the textbook, and they're basically generalizing for the whole United States. Every hospital is different. Every city is going to have different policies and procedures. We do have private rooms, but we don't necessarily demand that the patient keeps the door open at all times. However, if somebody was at very high risk, more than likely they would be on a one-to-one. So they would have a sitter. They would have somebody with them within arm's reach at all times. So we do have patients that have private rooms. They are allowed to keep their door closed, but we are doing 15-minute checks, or again, if they're deemed at high risk, they would be on a one-to-one. Jump-proof and hang-proof bathrooms. 1K has done an amazing job of renovations over the last several years, so that now the showers and the walk-in showers and the bathrooms are really quite safe. Doors locked to non-patient areas. Basically everything is locked. All the rooms on the unit are locked except the patient's rooms, but of course, medication rooms, utility rooms, kitchens, the patients are not allowed access to any of those areas. They might not be on a med surg unit, but they definitely would be locked on a mental health unit. We always monitor for and remove potentially harmful gifts. So we have to see if a family member or friend is bringing something in for a patient, we would have to monitor that very carefully. Not only would somebody possibly bring in something that a patient could use to self-harm or commit suicide, they also might be bringing in drugs and alcohol. So 1K does have its own policy and procedure for monitoring things that patients might be receiving from visitors. In the patient's presence, assess belongings and search patient for harmful objects. There's a whole procedure for that. That is done on admission. That is not something that we need to know great detail about as a student, except that it does happen, that belongings are searched through and harmful objects are taken away and stored in a special room in a locker and given back to the patient upon their discharge, unless we happen to find something illegal, in which case we would not, if we found some drugs or drug paraphernalia, we would not return those to the patient, but loss prevention we would turn the objects over to them and they would take care of those things. And again, we have to always ensure that patients don't bring or leave harmful objects. And certainly that has happened before. We have found syringes in patients' rooms after they've been discharged. We have found drugs, pills hidden in different spots. So it's always something that we have to be very carefully monitoring that environment. That's just a huge part of our job. And that's really part of that whole milieu management that I was again talking about in Learning Plan 1. Again, back to the case study. Gina is hospitalized for suicidal ideation after 2 suicide attempts. For the first 2 days of hospitalization, the patient eats 20% of meals, which isn't very much, and stays in her room between groups. By the 4th day, the nurse observes that the patient is much more sociable, eating meals, and has a bright affect. So the question that goes along with that was, considering Gina's behavior on the 4th day of hospitalization, which factor should the nurse consider? A, the patient showing improvement and may be ready for discharge. B, the patient may have decided to commit suicide. The nurse should reassess suicidality. C, the patient is feeling rested, supported by the therapeutic milieu, and less depressed. Or D, the patient is benefiting from the antidepressant she has been taking for 4 days. So I'm hoping that you picked B, because the patient, 4 days is not enough time for the patient to show improvement because of the therapeutic milieu or medication. It is absolutely B, that the patient may have decided to commit suicide and the nurse should reassess suicidality. That is a big red flag that many healthcare practitioners even miss. So it is something we really have to pay very careful attention to. If a patient's only been there for a couple days and they make this immediate turnaround, it is very possible that they have made a decision to commit suicide and they are no longer wrestling with it. When people are feeling suicidal, they are wrestling with it. They're very ambivalent in the beginning. They're going back and forth and should I, shouldn't I, weighing the pros and cons, looking anxious. They look distressed. They're struggling with whether or not to follow through with this. So if they've made a decision to commit suicide, they're no longer struggling. They may actually look pretty good. They may look at peace. They may look happy. They may look content. And if you ask them verbally, unfortunately, most of the time they will not tell you that they're feeling suicidal. So because they don't want anybody to interfere with their plan. So unfortunately, they are at very high risk to follow through because they often tell us that they feel great and everything is wonderful. They may sound like they're future oriented, all the wonderful things we're looking for when we're ready to discharge somebody. And I have seen this happen over and over again where that person will be discharged and they will commit suicide. So it is something, and it is hard. The hard part is that the patient isn't always honest. So doing the suicide assessment, the nurse really has to be aware that the patient may not be verbally telling them the truth, but they have to look for other signs like giving away favored possessions or tying up loose ends, not making appointments. There's other things that they may have to look at that are a lot more subtle. So, a little bit on non-suicidal self-injury, and then we'll be done with this learning plan. So, it is really quite a bit of a common problem. I read an article a few years ago that it is actually very, very common among college students. So, cutting, any type of self-injury that we can think of. Cutting is probably the most prevalent. So again, the intention is not to end their life, but it is usually to help them they report feeling better. So things that people commonly do: cutting, of course, burning, scraping, scratching, biting, hitting, skin picking, and interfering with wound healing. So keep picking open scabs. That can be another thing that we see. And there are ways that patients can do this on 1K. You can use your own fingernails to scratch yourself. They give out golf pencils, and you certainly can scratch yourself with a golf pencil. Patients have done that. So if we find that people are self-injuring with common things that we consider safe on the unit, we might still have to take those things away. So on page 486, your book talks about the epidemiology, and they talk about the prevalence, and basically it's estimated that between 13 to 23% of adolescents engage in this behavior. It is hard to sometimes quantify that and put a number to it, only because many people that self-injure actually hide the behavior. They may wear long sleeves. They may wear short pants in the summertime instead of shorts because they don't want anyone to see their cutting. Usually when people are cutting or self-injuring, they're doing it in secret. They're doing it privately. They're not doing it openly in front of other people. So sometimes it is kind of hard to kind of put a number to that. Actually, they're estimating at about approximately 6% of the United States population has engaged in this behavior at some time in their lives. That's actually, still a pretty significant number. And I have read other articles that talk about it is truly an age-wide lifespan issue, that not only we think about maybe adolescents or young adults cutting and self-injuring, but actually this behavior can persist into middle adult and even old age. I have seen middle age to almost older adult, like 50, 60-year-old patients who are still self-injuring. And sometimes the self-injury goes on for about 10 years, which really is quite a long time. So for comorbidities, this self-injury often occurs with other mental health disorders, such as depression, anxiety, eating disorders, and substance abuse disorders. So we always have to think about that they probably have an underlying mental health issue. I've actually seen people with bipolar disorder also engage in non-suicide self-injury. As far as the cause, it sounds like biologic factors are kind of inconclusive, and that more research is needed, but it looks like it's possibly related to levels of neurotransmitters the same way. If you think about it, that makes sense with people having diagnosable mental illnesses. Cultural factors, I have read, the book kind of talks about similar rates occurring in the United States versus Europe. I have read articles that really talk about that it is absolutely a worldwide problem. People in all cultures and all across the world actually engage in self-injurious behavior. Societal behaviors, it might be a phenomenon that sometimes we see in schools. Again, we can have copycat people that do like copycat self-harm. Somebody talks about harming themselves, scratching themselves, and somebody else tries it because the other person said that it helped them to feel better. So sometimes just that interaction with other people that are self-harming can lead somebody into that behavior. And your book even mentions at the top of page 487 that sometimes we see that phenomenon in hospitals where if one patient is starting to self-harm, say they use a golf pencil to scratch themselves, next thing you know, we have a rash of other people starting to find things that they are self-harming with. Your book also says that basically non-suicide self-injury, it's not an official disorder, so people aren't going to be diagnosed with that using that DSM-5. However, it certainly is a behavior, it's a coping mechanism that people have learned to use, but it is considered an ineffective coping mechanism. So we're always using the nursing process. We're assessing people. The importance of empathy just can't be understated. So if somebody is self-harming, many times their self-esteem is already very poor. They're hiding their behavior. They know that other people will frown upon it and look upon them perhaps in a different way if they knew they were cutting. So they do try to hide many times their behaviors. They have a very hard time with sharing that with other people. So the importance of being empathetic and really understanding the feelings behind the cutting. So just to understand that the cutting is really representing their psychological distress. So if we feel that way, then that can help us to have more empathy. We always want to be looking for triggers, and the triggers are going to be different for different people. And again, self-assessment, some medical professionals get very frustrated with people that self-harm. They feel they're doing it on purpose to, quote unquote, get attention, and then therefore can really have a lack of empathy and possibly even treat that patient in a manner which is going to further erode their self-esteem. Then they're really not going to feel good about themselves if they're being treated poorly by health professionals. And sometimes I've heard stories. I'm not picking on emergency room people, so if any of you are working in the emergency room, I am not picking on you. But sometimes I've read articles where people get treated kind of poorly in the emergency room because the personnel just doesn't understand the dynamic behind the cutting, that it truly is a representation of their emotional distress. And so sometimes they're treated very poorly. And I have heard stories about doctors not even using any kind of local anesthesia when they're suturing up somebody's cuts, because after all, they did it to themselves. They cut themselves. So to inflict a little more pain is not a big deal, or shouldn't be a big deal. Or just treating them like they're an annoyance, or, I've got better things to do, and here I am stitching you up when I could be helping that person with, the kidney failure or heart attack. And you're just made sometimes to feel very low when you're in that position. So we really have to be very aware of our feelings when we're working with people that self-harm. Some nursing diagnoses that we're going to be looking at are risk for self-directed harm, of course, would be probably the biggest nursing diagnosis. And for outcomes, we want the people to use better coping mechanisms. We want to improve their social support, maybe help them feel less isolated, and feel a sense of self-esteem. If you feel good about yourself, you're less likely to cope in a way that is injurious. So there is a nice 6-step approach that your book talks about: limit setting for safety, developing self-esteem, the discovery of motive and its role, discovering self-control, replacement with other more positive, healthy coping skills, and entering the maintenance phase, where hopefully that person will no longer be cutting themselves. It is an old adage that you can't take away a coping mechanism without giving the person another one to replace it with. So this would be a great example. We can't just tell people to stop cutting without giving them another way to cope. And again, I'm going to always put a plug in for group therapy on 1K. It is just an awesome experience. The occupational therapists do a great job of really giving the patients a toolbox of different coping mechanisms that they can work with. The other thing that I want to mention with working with patients that self-injure is that it is really important for us to have just a very neutral, matter-of-fact approach. We have to assess their wounds. We can't ignore them. So you might think, well, you don't want to give them too much attention around their cutting, and that's absolutely true. So we don't want to respond with highly emotional responses, whether they're positive or negative. We don't want to be like, excessively worried about infection or just excessively responding emotionally to the, gosh, somebody once had cuts all the way from their wrist all the way up to their shoulder, and you can't like respond with horror or shock when you see something like that. You just have to look at it very matter-of-factly and not we don't want to give the patient a lot of attention around it, but of course we have to make a skin assessment, and we do have to see that they're not getting infected from those cuts. So that is a very important part of our interaction with the patient. Just be very matter of fact, make an assessment, but we don't want to show a highly charged emotional response to their self-injury. So we do need to care for the injuries. Again, establishing that therapeutic alliance is very powerful. Teach coping skills and promote a reflective dialogue. So help the patient to think about what was going on before they started cutting. So if they can kind of recognize some of the difficult emotions and feelings that they're having before they cut, that could actually be very helpful to them in thinking about other ways to kind of get around that, so they can figure out another way to cope and then prevent that cutting behavior. And then, of course, the advanced practice nurse is going to perhaps provide treatment of their underlying mental health disorders. And we all do evaluation. The advanced practice nurse does, and we always do too as staff nurses, evaluate the patient's response to our interventions and to the goals. How did they meet their goal? Are they cutting less frequently? Are they able to verbalize what triggers them to cut? Are they able to verbalize other ways that they can manage their emotional distraught when they feel like cutting? So, audience response question: a person with which psychiatric problem is most likely to complete suicide? It's a little bit of a trick question, but there is one answer that is more right than others. And really, that's what nursing school is all about, isn't it? Picking the answer that is the most correct, even though they all might be correct. Okay, anyways, so personality disorder, major depression, substance abuse, or schizophrenia. So I'm hoping you picked major depression, as that is the disorder that is most likely to end with suicide, but certainly people with personality disorders also commit suicide. Substance abuse and schizophrenia, they all do, but major depression is just a little bit more likely and more common than the other disorders. Another audience response question: which method of suicide has the highest lethality? Ingesting pills, cutting one's wrist, inhaling natural gas, or self-inflicted gunshot wound. So again, I'm hoping that you picked D as the most lethal method according to your book, and that is the end of Learning Plan 3.